Thanks, Greg. And good morning, everyone. Thank you for joining us and being with us here today for today's Knockout Opioid Abuse Day Learning Series webinar. This webinar series is a continuation of Knockout Opioid Abuse Day, which was designated as October 6th each year by Governor Murphy. And this learning series is designed to continue the awareness and education highlighted by that initiative throughout the year. Today's webinar, The Opioid Epidemic and the Impact of Race, is a very important topic, and we're so pleased that we can bring focus to it. This webinar is brought to you by the Partnership for a Drug Free New Jersey and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General. And I thank them for their partnership, support, and collaboration on today's learning activity. I'm so pleased today that we have with us Attorney General Andrew Bruck. Andrew Bruck was appointed the Acting Attorney General in July 2021. And he joined the Office of the Attorney General in January 2018, and he served as Executive Assistant Attorney General and then First Assistant Attorney General. Previously, he spent 5 years with the U.S. Department of Justice, where he served as Assistant U.S. Attorney in Newark and held several roles in the Office of U.S. Deputy Attorney General Sally Yates, including Senior Counsel and Acting Chief of Staff. Attorney General Bruck, we're so pleased to have you with us today to provide some opening comments and to shine a light on this important topic. Thank you.
Thank you, Angela, for that introduction, and thank you to everyone for joining us today. I really am so appreciative to the Partnership for a Drug Free New Jersey and to NJ Cares for sponsoring this webinar. It's such an important issue, and I'm so glad to see a focus on the topic of not just opioid addiction, but how it intersects with race. Look, big picture, New Jersey has made some real strides in our fight against the opioid epidemic during the Murphy administration. We are focusing on comprehensive, data-driven strategies. We are increasing access to addiction treatment and harm reduction resources. We're promoting diversion and alternatives to criminalization of addiction. And I think there are some recent developments that make it more likely that we win this fight. Our lawsuit against opioid manufacturers and distributors will bring hundreds of millions of dollars into New Jersey to combat the epidemic. And our efforts are reinforced by the Murphy administration's new partnership with Bloomberg Philanthropies. So there's a lot to be optimistic about. But as we work to knock out opioid abuse, we can't afford to leave any community behind. And that's why when we talk about combating opioids, we also need to talk about race and racial justice. I think there was a time when the public discussion about the opioid epidemic focused on how white Americans were hit particularly hard by this issue. And I still think that in the public mind, opioid addiction is linked with folks living in rural West Virginia and other parts of Appalachia. But as you're going to hear today from state police, that's not the story of opioid addiction these days. Overdose death amongst people of color, and especially among Black people and Hispanic and Latino people, is rising, and they're rising faster than the rest of the population. So when people of color represent a larger and larger percentage of all drug overdose deaths, it's happening at the same time that the total number of overdose deaths in New Jersey is holding relatively steady. And this is the statistic that just boggles my mind. In 2015, Black, Hispanic, and Latino people made up about 22% of all drug-related deaths in New Jersey. And now we estimate that it's around 40%. I mean, that is just a breathtaking change in a short amount of time. And these numbers underscore the need for a racially inclusive approach to addressing the opioid crisis. And we're committed to that path so that we ensure that no one is left behind. As I said, I think our approach to this issue is comprehensive, but I want to just mention quickly a couple of things that we're doing to address racial disparities in particular. First, we're being transparent about the numbers. We're acknowledging these trends because that's a necessary first step to addressing inequities, and that's exactly why we're here today. It's a first step, but not the only step. The second thing that we're doing is that we're working to address racial disparities in healthcare. We talk about how the opioid crisis is a public health crisis, but we also know that there are inequities in our healthcare system and that Black and Brown people have less good access to our healthcare system than other communities in the state. Through NJ Cares, we're working with Rowan on a continuing education program about opioids for healthcare providers. And part of the curriculum that we've developed with them is on implicit bias involving clinicians in pain management and substance use disorder treatment, and making sure that those implicit bias do not affect the way that doctors and other medical professionals think about the issue. And practitioners can access that training on Rowan's website anytime starting today. The third thing that we're doing to address racial disparities is by thinking about the criminal justice system's treatment of drug users more broadly. Not only are we prioritizing diversion, but we're also training our officers and prosecutors on implicit bias so that our diversion programs are not implemented in a way that perpetuate or exacerbate disparities in the system. But these are really just starting steps. There is so much more that we need to do, both in dealing specifically with the opioid crisis and in tackling the systemic and structural issues that have been in our country for centuries. Webinars like this are an important part of continuing and expanding that dialogue and identifying solutions that we can all work on together. So I am so pleased that this was organized and hosted, and I'm so grateful for the many hundreds of people who are joining today to listen in. So thank you, Angela, for having me, and I look forward to the discussion.
Thank you so much again. And your comments were so on point for this conversation and kicking it off and discussing those inequities. And we all look forward to your leadership as your office has continued to take such a leading role on addressing the opioid crisis in our state. And so we appreciate that. And we, again, appreciate you being with us today. I know that you have a busy schedule today and you have another event that you're headed to. So again, I want to thank you for your time today, your commitment, the commitment of your office, and all the attention that you've brought to the opioid crisis, and also your leadership in bringing this conversation about race to this topic of the opioid crisis. So thank you for that. And thank you again for the support of this learning series and being with us today.
My pleasure, Angela. Thanks so much.
All right, thank you, and have a wonderful day. We also have with us 3 expert featured speakers who are going to continue the conversation that the Attorney General has really set up the conversation for today. Captain Jason Petrowski from the Office of Drug Monitoring and Analysis with the New Jersey State Police. Dr. Robert Johnson, the Dean of Rutgers New Jersey Medical School and the Interim Dean at Robert Wood Johnson Medical School. And Jamie Gainey, the Program Manager of Cultural Connections with Family Connections. So I welcome and thank all of our featured panelists for being with us today. And Jason, I will start with you and turn things over. I know the Attorney General mentioned that you're going to go ahead and give us a real great snapshot of what's happening in New Jersey. So, we can really see how it impacts our state. So turn things over right to you now.
Okay, thank you very much. Good afternoon, everyone. Thank you for attending. Thank you to the Partnership for Drug-Free New Jersey and Attorney General Bruck for his opening remarks. I am, again, Captain Jason Piotrowski, the New Jersey State Police. I've been working on the overdose epidemic through the New Jersey State Police Drug Monitoring Initiative, or DMI, since 2014. Our program is a very data-driven program, and we've been collecting, analyzing, and reporting trends, patterns, and emerging threats since our inception. Today's presentation is going to focus specifically on race-related trends, but I am going to build a foundation before we get there. We are observing, regarding the overdose epidemic, significant changes in race-related trends. It's well known that addiction does not discriminate and anyone can be affected, but we're gonna talk about what has been happening with the demographics over the last several years that the Attorney General has alluded to. It's exceptionally important to understand opioids have become increasingly more potent and dangerous, as we've tragically been losing more than 8 people every day in New Jersey due to drug-related deaths since 2018. It's imperative that we understand those most affected populations so we can ensure that support services and resources are equitably and appropriately provided to our citizens to have the most impact in reducing community drug harms. Can you go to the next slide, please? Our drug monitoring initiative started in 2014. It was primarily law enforcement focused. However, over the years, seeing the impact that opioids had on our communities, we've transitioned to more of a drug harm reduction posture and have developed a more comprehensive and collaborative approach. We have way too many partners and sub-initiatives to name here in this venue, but again, the focus of my team is to utilize our resources to understand and reduce community drug harms. You can go to the next slide, please. For the sake of time, I'm not going to spend a lot of time on this slide here. This is our data sources and methodology, but you can, if you're interested in this, you can view it when it's posted. Next slide, please. For the DMI program in general, these are the data sets that we use to analyze the drug environment, totaling almost 40 million records, which each record also has many data points as well. And at this point, I just want to recognize my small dedicated DMI team for all the great hard work they do in pulling all this data together so we can understand the environment. For this presentation, we're going to be focusing on the naloxone administrations, the drug-related death data, forensic lab data, and treatment admissions data. You can go to the next slide, please. For these next two slides, I'm just going to convey the magnitude of the overdose epidemic, both nationally and in New Jersey. You can see the two primary causes of unintentional death in the United States for ages 1 to 44 reported by the CDC. Around 2011, 2012, we see that drug overdose deaths surpassed motor vehicle accidents as the #1 cause of unintentional deaths nationally. Next slide, please. In New Jersey, however, this happened around 2001, and you can see the gap kind of continues to widen. You can go to the next slide, please. Primarily, when we're talking about drug-related deaths, we're talking about opioids. This chart illustrates the overwhelming involvement of opioids in drug-related deaths. Again, this is from the CDC. Next slide, please. Through our partnerships with our criminal forensic labs throughout New Jersey, we receive forensic analysis of the results of drug seizures. And you can see that fentanyl was found in only 2% of lab submissions of suspected opioids, being what was historically heroin. In the first quarter of 2015, now fentanyl class compounds are found in 96% of submissions statewide. You can go to the next slide, please. I'm going to go back to the national perspective for a second. Through 2019, while all groups are showing an increase in rate of drug overdose deaths per 100,000, nationally, the Black population has the highest rate at 25 deaths per 100,000, and the Hispanic population continues to see significant increases as well. The white population is seeing its first decline after having peaked in 2017. You can go to the next slide, please. Contrast that with New Jersey. All populations have been affected more than what we are seeing nationally, and with the Black population being the most significantly affected at 47 deaths per 100,000. That is a full 62% higher than the white population and 34% higher than the Hispanic population. You can go to the next slide, please. Moving forward, we're going to look at another way to understand New Jersey data trends and drug harms. And for context, this slide depicts the statewide demographic data. So again, due to time, we're going to be focusing on the state as a whole for all intents and purposes. So that's going to be that bottom row there. And what we're looking at is 51.9% for the white population and 12.4% for the Black and African American population and 21.6% for the Hispanic Latino population. And this is taken right from the Census Bureau data, 2020 Census Bureau data, and that's how they break down the population groups. You can go to the next slide, please. Now, this is going to be more recent data than what I just showed you, and now we're going to slow down a little bit. On the left there, you're looking at the first 4 columns are naloxone administrations, and then the columns to the right are drug-related deaths. For the first column on the very left, that's naloxone administrations for the white population, and then again, closely correlated to that is that 5th column where we start showing the drug-related death data. And you can see those are going to be very closely correlated because obviously naloxone administrations, overdoses, and overdose deaths, a lot of times they are there's some intentional double reporting in there, but those are going to be very closely correlated, obviously. We're seeing the impact to the white population decreasing over time from 2015 to 2021. And we're seeing the impact of the Black population increasing, obviously correlated to that. And the naloxone administrations of drug-related deaths are seeing the same thing. The most recent census denotes that the Black population is only 12.4% in New Jersey. However, Black residents are currently and increasingly becoming more afflicted and more at risk than any other time during this pandemic. You can go down to the next slide, please. This is just another way to depict the same data. And what you can see essentially is the blue lines are naloxone administrations and deaths to white residents. And the orangish lines represent Black residents and the gray lines represent Hispanic residents. In 2015, there's a very big disparity. And over time, we can see those lines getting closer and closer. So again, that's the same data, it's just another way to look at it. You can go to the next slide, please. On this next slide, we're going to introduce demographic data to include some gender and age data for simple awareness. The gender data remained very consistent over this reporting period. 72% male and 28% female generally holds through these last 5+ years. The age categories, though, tell a different story. The age categories mirror those used by the New Jersey Substance Abuse Monitoring System, so we can match our data with theirs. But what stands out here is in the bottom row and the increasing red going across the page. That's tracking with the increasing red in the race category. And that 55 and older demographic has increased in drug-related deaths every year. The 55 and older demographic has become the most afflicted group over time, both fatal and non-fatal overdoses. On one positive note here, we are seeing the smaller percentage of younger populations affected over time as well, commensurately with that. Next slide, please. Now, we don't have the time here to dig into the county by county details, but here are some significant trends that are identified by our DMI analysts. In these counties here, there are significant increases in the afflicted demographics from what we were seeing in 2015 compared to 2021 data. The population, with the exception of Hunterdon County, the Black population and the Hispanic populations have seen the most significant increases in drug-related deaths in these counties. So again, Atlantic County there, 317% increase, Hudson 220%, et cetera. I can go to the next slide, please. I'm going to shift over to naloxone administration data now and look at a little bit more granular. As we've seen through this presentation, naloxone administrations and drug-related death data are closely correlated. And again, sometimes there's purposeful double reporting there between those categories. However, with the naloxone administration data, we have access to more specific real-time data. And so what we are looking at is municipalities with more than 100 administrations, naloxone administrations or overdose events through the third quarter of this year. These 14 of the state's 577 municipalities account for 41% of the state's total naloxone administrations. You can go to the next slide, please. And this slide really tells kind of an interesting story here of the transition of the demographic. We're looking at these municipalities by age category, race, and gender. And the 55 and older Black male and females are predominantly the most at risk in the most afflicted areas of the state. So again, the most naloxone administrations or overdoses are happening in these locations. And we're consistently seeing the 55 and older Black males is the #1 category there. And that's something that, to do outreach and resource allocation, we really need to understand that demographic if we want to have a positive impact. You can go to the next slide, please. This is a geographic depiction of the distribution of race related to naloxone administrations by county in 2020 and 2021. Again, those small tables there, they show a snapshot of the recent changing demographics at a statewide level. And you can see just in 2020 there, white was 50% and it went down to 47%, and Black was 25%, went up to 29%, and Hispanic was a small change. You can go to the next slide, please. I'm starting to wrap up now, and I'm going to talk about treatment admission data very briefly. This was received from our partners at Department of Human Services. And it's looking at treatment admission data trends for all drugs from 2016 to 10/31 of this year. There's an increase in treatment admissions yearly from 2016 to 2019. However, this changed in 2020. And our treatment admission numbers are still not projecting to previous years for 2021. What happened here is we saw a sharp decline in 2020 in many categories, including law enforcement users, transports to hospitals after overdose, along with treatment admissions. And that began with the onset of COVID-19 pandemic in 2020. So, you know, that is problematic for our communities if we were seeing pretty good increases in people getting treatment, and we're not seeing those same numbers now post-COVID. On an interesting note, when we look at the treatment admissions by race from 2020 to 2021, we're seeing the biggest increases in treatment admissions in the Black and Hispanic populations. And another thing that's interesting is if you calculated the percentages of who's receiving the treatment in 2021, they actually align almost exactly with the drug-related death statistics as well. So I thought that was kind of interesting and somewhat encouraging, as kind of the Attorney General mentioned earlier, of all the efforts that are being done. I was pleasantly surprised to see that it seemed like there was some equitable across the board population trends. You can go to the next slide, please. This slide breaks down the opioid admissions data by heroin, other opiates, and oxycodone. Again, that last slide was all drugs, and this is breaking it down a little bit more. Some of the points our analysts pulled from the data are there on the right. And you can go to the next slide, please. Lastly, I'm going to wrap up here on this slide. I am generally the bearer of bad news for many years when talking about the nationwide overdose epidemic. However, the question, how is New Jersey doing as a state compared to the rest of the country? And again, the Attorney General kind of alluded to this. I took this from the CDC site yesterday. We are only one of 4 states that's showing a decrease during this time frame. With the increase in fentanyl to almost 100% of our samples from about 50% in 2018. For all intents, our drug-related deaths have remained flat, hovering around 3,000 per year. Again, according to CDC data, the country as a whole is up 28% during this time frame, and about 38% from 2018 to 2020. Again, we've remained relatively flat, but we still have a lot of work to do. And specifically knowing the populations we need to target for outreach and support is important. So I hope some of this information was helpful. Next slide, please. These are just my sources. Again, this will be made available. And the next slide. All right, there's my contact info if I could be of any assistance, or my office can be of any assistance. And I'm really looking forward to the next presenters. Thank you very much.
Thanks so much, Captain. I think the information you shared specifically about the fact that New Jersey is one of only a few states that had a decrease do reflect on all of the efforts, I think, in all of the ways that so many have been coming together to address this issue, that collaboration. And so thank you again for sharing that. Dr. Johnson, I'm going to turn this over to you now. So pleased that you could be with us, and looking forward to your expert comments.
Good morning, everyone. Let's go to the next slide. I want to start with my takeaway. And the takeaway is that the healthcare profession and medicine in general are key to the development of the opioid epidemic in the United States, as well as key to the issues that surround the racial disparities that exist there. Before the beginning of the 20th century, opioids were one of the most important medicines in medicine. And you see here a list of the conditions it was commonly used for. The first 4 are infections, and although opioids do not kill germs, they do have other properties that help save lives of individuals who had these infections. Dysentery, which is one of the most common causes of death up until that time, caused diarrhea, which caused dehydration and death, and opioids will cause constipation and decrease in the movement of the gastrointestinal tract, and improved outcomes of dysentery. Cholera, malaria, And pneumonia are associated with a great deal of pain that affected the ability of individuals to breathe, and the opioids were successful in helping individuals with those conditions. Then menstrual pain, painful injuries, even depression and anxiety were treated with opioids. And next slide. When we had major crises in the United States, all of these conditions, especially dysentery and especially injuries, increased significantly. And there was a major increase in the use of opioids by the medical profession. The most important period that this occurred in was the American Civil War. And so one of the things that happened as a result of lots of dysentery and lots of injuries, lots of amputations, was that we ended up with many, many veterans from the Civil War who were addicted to opioids. But for the first time, we began to see differences in outcomes due to race. Now, the Black soldiers here in this slide, if they had dysentery or if they had an injury, they would look for a healthcare provider, and it may be very difficult for them to find a healthcare provider because they were not usually available to them. It was unusual for them to receive the same treatments for dysentery that were received by the white soldiers. And one of the interesting statistics that we do have is that the death rate for Black soldiers with dysentery was 35%, but with white soldiers it was 17%, primarily because of the use of opioids. In addition to that, Black soldiers who were injured were less likely to receive the opioids to help control the injuries they had. So we first began to see differences in the way in which physicians made decisions, or healthcare entities made decisions about treatment based on race. There was a belief that Black soldiers resisted pain more than white soldiers, and therefore the Black soldiers, or African Americans in general, Black people in general, needed less pain medication. And there were all sorts of other issues that were a result of racial discrimination. Well, the result of that was that the amount of opioid addiction among African American veterans of the Civil War was much less than the addiction among white soldiers of the Civil War. Next slide. These things have not changed very much. We still, in the current opioid epidemic, where decisions made by physicians for treatment for pain are key to the overdose of opioids. In other words, doctors, in an effort to decrease pain felt by their patients, were more likely to prescribe pain medications in higher amounts to white patients than were to Black patients. Black patients were also less likely to find those healthcare providers. As a result of that, there were larger numbers of white individuals who developed opioid addiction than white individuals. Now, turn that around. The disparities that exist not only had this outcome of that's associated with differences and occurrences of the condition, it also had some very important outcomes with the availability of treatments now that we have treatments available. Let's go to the next slide. This is a series of 6 quotations from an article that was recently appeared in, or actually a couple of years ago appeared in Psychiatric Times, and talks to what are the experiences of African American patients when it comes to seeking care for opioid addiction. And one of the things is you have to be in a community where you have hospitals that supply it. And you see that Caucasian patients were 35 times more likely to find it available in the hospitals that they visited. There was the financial difficulty too, because patients of color more likely didn't have insurance that would pay for it. Next slide. In addition to that, doctors found, and African-American patients found that the doctors, especially doctors who are not African-American, had a mistrusting relationship with them. And doctors, even today, were still making decisions that were based upon biases that the doctors had about Black patients, and was less likely to provide drugs to them. Next slide. All of these things are associated with a very important issue in healthcare, and that is health disparities, health equity and inequity. Next slide. And the social determinants. And social determinants are key to many of the outcomes that exist in healthcare. And we are making a strong effort in medical education as well as in design of healthcare to make sure that we account for these social determinants, because the outcomes that patients have are not only related to the medicines that we provide, but all of these other things. You see education, housing, the neighborhoods, the justice system, race, gender, sexual identity, all of these things affect the outcomes that are received, and we have to account for them in order to counteract the health inequities. Now, the next slide, there are a few specific social determinants that are related to substance use disorder. One of the key ones is socioeconomic status. Now, one of the other things you're going to see is that these social determinants don't stand on their own. They are connected to each other. So socioeconomic status is a strong predictor of quality of care that you would get in general. Well, it's a strong predictor of whether or not you have health insurance, strong predictor of whether or not you live in a community where you have the best healthcare provided, and therefore it is a strong predictor that you, number one, and very interesting situation with opioids, it's a strong predictor that you would have encountered a healthcare provider who's more likely to overprescribe pain medications to you at a time when one of our key drivers was decreasing pain. But it's also a strong predictor that if you did develop opioid addiction, you were able to find treatment for opioid addiction because of your socioeconomic status. Next slide. Well, that's related to education, because the better your education, the better your socioeconomic status. And so those two things connect to each other for both of those particular outcomes. The occurrence of the addiction in the first place, the overprescribing, as well as the access to treatment. Next slide. Then we get to race. Those two things are predictors, except when it comes to race, because race erases the advantage of socioeconomic status and education. And this is related to structural racism. And structural racism is a term in which we roll in all of these things, the design of systems that result in differences in treatment by race. The law is a very good example, and the way in which laws are enforced. The personal biases, implicit biases that individuals have is tied into that. So all of these things are connected, and it's important for us in the healthcare community to understand how structural racism has an effect on these other outcomes. Next slide. And then those are all connected to the environment as well, which is predicted by your socioeconomic status, predicted by education, and also predicted by social structural racism because of the redlining practices that were actually in law in the United States more than 30, 40 years ago. Next slide. And then the provider factors. And one of the things that we do in medical education is to make sure that we equip our physicians with the skills necessary to understand their own personal biases and to see how their biases affect the way in which they react to patients, decisions they make about patients, and then how the environment may affect what goes on with patients. Next slide. So that is how all of these things roll into each other. That healthcare has resulted in this problem. Healthcare within the context, especially of structural racism, especially in the context of some of the socioeconomic and social determinants of health, has an impact on how the problem developed, has a huge impact on how we are to resolve it. If we are to significantly resolve the issues, then what we need to do is to be aware of, at least in the healthcare community, how we are impacted, and we are making an effort to do that. But also, it is not just an issue that can be resolved by healthcare. Housing, for example, is a very important determinant of outcomes when it comes to both exposure to the possibility of opioid addiction, as well as to the outcomes. And that's something that can't be resolved by the healthcare community, but the healthcare community and public health can participate in that. So thank you very much. I look forward to your questions.
Thanks so much, Dr. Johnson. What a great historical perspective that you provided, talking about this issue and race and inequities that have existed. I think it will really help us as we move forward in developing strategies. So thank you for that. Moving forward to our final speaker, Jamie Gainey, the Program Manager of Cultural Connections with Family Connections. Jamie and I had the opportunity to connect earlier this year, and so happy that she could join us today to shed some light on some things that we can do, some action steps and some ways that we can implement in our strategies. So welcome, Jamie.
Thank you so much, Angela, and thank you to all the speakers before. Great information on data and systemic racism and the history of opioids in healthcare and social determinants. I'm going to dive right into structuring equity in this fight. Next slide. It's all about the cultural inclusivity in policy decision-making when we're talking about the provision and collaboration around care and recovery. And there's a set of, I just want to acknowledge there's a set of beliefs, practices, values that actually influence this room today. It's culture. It was set in motion by experiences and decisions we've had, by leaders, policies, practices. Every room, relationship, team, community, organization, you name it, has those pieces in it. So we actually have the power to reflect more inclusivity in our decisions and our policies and our practices, and all of those spaces in our healthcare ecosystem. So just a bit about our programs. Family Connections has been on the cultural competence journey for more than a decade, and a key manifestation of that journey, our program Culture Connections, is a training and technical assistance and coaching program focused on supporting providers and leadership across agencies around building cultural competence into what we're doing to serve our populations and create more equitable outcomes. Another manifestation of our cultural competence in our own agency is actually our ADAPT program, which I'll talk about a little bit later. They are key in advocating for systemic change in the opioid use disorder population, and they are focused on reducing substances in the community, and they've had some really impressive impacts, again, thinking about this community cultural piece. Next slide. So cultural competence is what we do, and today I'm going to kind of give you a snapshot of actually what our coaching looks like. I thought that was the best way to sort of convey how this works and some of the outcomes. When we talk about disparities in accessing resources, prevention, treatment, and recovery, what we're really identifying is the inequities that come from not being counted, not being heard, some of what Dr. Johnson talked about earlier, old ways of thinking, systems that previously had dehumanized instead of humanizing people, not as much accountability as we would have liked to see, some Band-Aid solutions, and homogenous rooms that don't include diverse stakeholders in decision-making process. So what we're talking about really is these spaces are coming out of the need for us to connect around culture to understand our issues and our solutions a bit better. Next slide, please. So when we're looking at making prevention and treatment and recovery accessible, a lot of these decisions that have been made, again, we're looking at how that can be impacting our space in the future and addressing these issues. There's a lot of money in this fight right now. So when we're looking at resources and how we can impact treatment, culture in this conversation can shift how resources are allocated to the populations that need it the most. Are we honoring diverse cultures and experiences at the decision-making table? Who else needs to be at the table? And can we shape the allocation, again, to make sure it gets where it needs to be? This is the coaching process that we kind of go through with organizations that work with us. We're talking about acknowledging biases that exist in these decision-making spaces and how it is an active process in order to undo or redo our approach to make services more accessible. And of course, when we factor in a more inclusive approach, things like cost, can be impacted as well. We're spending less time spinning wheels and solving issues because we didn't include the right perspectives or the more inclusive perspectives at the table to come up with solutions. Next slide, please. So I want to show you some examples of some decisions that have had impact on access. And if you can't see the font, I apologize, I'll just point them out. One of the decisions articulated in this article talks about providers that were making decisions about who was getting medication and how that impacted access to recovery. If we're looking at how we're going to address this issue in our system, we need to look at the decisions that are being made, both on the individual level and also the provider and the system level. And if we go to the next slide, I'll show you some of the systemic piece or the systemic decision-making. In this article, it talks about initially, when they looked at death rates, they were flat in their initial look. But that second statement there where it says, but looking more closely, they found that there was an increase among Black people. So note that that wasn't the first look, that was the second look or the third, or we don't know, but it wasn't the initial. So you start to think about when folks were at that table, what decisions were happening, what representation was in the room, who was putting on the table the fact that we needed to be looking at maybe more than was initially looked at. So when we're talking about how to have an impact on access, you can see clearly how we have to work on who's in the room to make sure that things are not missed. And we're doing some of that work now. We're asking everyone to take that closer look the first time. Next slide. So let's look at how this can change access to the landscape when we're thinking about the decisions, and then we'll get into some outcomes. Next slide. So we've talked about, we've gotten some great information about a shift in the data collection, right? The data was not always there and now it is being collected. And we know when we have the data, we can actually measure an issue inclusively and accurately, and we can create solutions around things that we can see. When we have data, we're able to look at the impact in terms of what we need to maybe overcorrect for that we had not been addressing initially. We also look at, when we're collecting this data, is it inclusive and are we assessing for it to be inclusive all of the time? We can assess, is it inclusive in one area at one particular time? And then, several years down the line, we know culture and everything shifts and we haven't looked again to see, have we factored in maybe new data points? Have we factored in other cultures that have come into our space that we need to be measuring for? So doing it often is going to help us increase access when we know that culture shifts. In terms of methodology, even, are we collecting data in a way that reaches the people we want to reach? It's not, the necessarily one size fits all kind of approach. We need to make sure we're inclusive even in how we're getting data. And when we can gather it effectively, we can serve folks effectively. Things like county breakdowns. Do we look more at, can we break it down further into localized data to support providers in those regions that are providing the services? So again, kind of looking at cultural piece and saying, what are some ways that we can make this more inclusive so we get the data we need to serve folks? Next slide. In addition to the data collection and methodologies, there's assessment piece, right? Making sure, again, that we are inclusive in how we are getting information, disseminating information, who's at the table, are they representative of the communities that we're serving? If we find that there are gaps in representation, we can start to see how that can shift our policy and our decision-making where it's not as inclusive as it needs to be. Next slide. In addition to the assessment piece, there's a piece of it that involves our approach being inclusive. So if we are in the community that we are trying to serve, are we really in the community? or are we just living in the community, so to speak? Are we doing life and getting involved and having those connections? Additionally, in the community, are we taking advantage of the expertise that exists there, right? This coalition concept where we are pulling all folks to the table to see how we can better serve the community. Next slide. So this model allows us to, again, bring folks to the table. It's a coalition model that means that all parties that are involved are pouring in terms of strategy, they're pouring in terms of responsibility, as well as resources. And our program ADAPT, as I mentioned earlier, uses this model in a way that has already reduced tens of thousands of drugs on the street and has established partnerships where we're able to work with police departments around increasing disposal of prescription medications in the county. So taking that community coalition building, diversity, cultural competent model and using it to have some real impact in our community. Next slide. Lastly, or not lastly, but again, when we're talking about the decision making, back to that piece about homogenous rooms, we cannot be inclusive if our rooms don't look inclusive. We're sending messages where concerns won't be put into policy if there aren't enough voices at the table that are bringing all the concerns. Making sure health equity is everyone's job. And I want to say that again, because if it's not someone's job, there's no guarantee that they're going to do it. So when we're talking about providers, we're talking about leadership, making sure that health equity is what is literally what we're accountable for when we do our work in this fight. Also, things like modeling what you mandate, make sure that you're practicing what you preach. Recruitment in terms of looking at these communities for who do we need on board to support us that's coming right from the community, making sure that equity is in the process, and also looking at the way we speak to each other about these issues, knowing we're representative of different cultures and we're serving a community that needs our help. We need to make sure that we are safe and bravely having these conversations in a way that produces fruitful collaboration. Next slide. So here are some of the outcomes. This is recent and a perfect example, although I wasn't at this table. Here's where a service was expanded in terms of treatment hours. Think about what that might have looked like at a table where we were bringing together diverse needs, diverse observances about what is different for people in terms of social determinants of health, how that might have expanded treatment to reach more people who needed it. Next slide. Again, this is how our agency models culturally competent decision-making and partnerships. And we've had some major success here. ADAPT, has had events in the community to support the reduction of drugs in the community. Again, that huge number, 19,000 pounds, which is an amazing. You can see our partners also on the side there that we are collaborating with in our coalition in the community. And in 2022, we're looking to create a countywide substance use related epidemiological outcomes work group that's going to increase our data points around speed of response, innovation, and funding. So again, that sort of community collaboration, cultural piece in there. Next slide. And in terms of culture connections, we have done our work in terms of reaching out with this coaching to reach leaders, to bring them into this conversation and have them look at their policies and practices differently. And these are some of our successes. We've had cultural and strategic plans created around health equity, again, and influencing that decision making all the way down to our services and outcomes in our system, and impacting leaders to think more about health equity, and in our own organization, planning as well around how do we reach the communities we want to serve. Next slide. So I know I raced through a bit and I hope everyone got it, but I just want to leave you with this final point. If you are looking to make more of an impact, providers, community partners, institutions, state committees, look at the way that decisions are being made and the outcomes. And if there's any stagnation, roadblocks, miscommunication, unexplained issues, I urge you to look at the organization culture and see if there isn't room for discussion about how that might be influencing the decisions we make and the chance we have in fighting disparities in this crisis. If we can change the landscape We can help save lives. And if you are looking for support, we're happy to come alongside you and unlock some greater results. Thank you so much.
Thanks so much, Jamie. Just excellent presentation and some really valuable tips. It really goes into my first question, which I was going to throw to you, but I'll start with Dr. Johnson, and then if you want to jump in on that, you can. Can you provide, so Dr. Johnson, we'll go to you first. Can you provide the top 1 or 2 recommendations on programming or next steps for those in the audience who are creating community coalition prevention programming or curriculum for colleges? Is there any recommendations that you can give to address disparity and equity issues in regards with substance use disorder?
Well, you know, my particular area of expertise is in healthcare, and so if you are involved at colleges and universities in healthcare curricula, you do need to have curricula that involve health disparities and structural racism. Now, that actually is now required by all of the accrediting bodies, and these things are not separated out. The same disparities that affect poor decisions that are made in surgical choices are the same ones that affect decisions that are made when it comes to opioid treatment. So we need to improve the cultural competence as well as the cultural experience of all of our healthcare providers, and then have open conversations about it. All of us have the ideas that we have because of what our experiences have been. And those experiences affect how we react to certain situations, but we do need to be aware of how we're reacting and how what we do and what we think affects what affects other people. And I think that's going to be, at least that's the approach we use in healthcare training at our medical schools.
Thanks so much. Jamie, was there anything that you wanted to add based on that question?
Thanks, Angela. I admittedly, I was so engrossed in what he said, I missed the question.
Oh, no worries. No, the question was just 1 or 2 recommendations for those. We got a variety of questions, but those who are creating programming at the community coalition prevention level, also college curriculum, any recommendations?
Yes. If I didn't say it enough, please bring culture into those conversations when you are creating anything. I think the biggest thing that we miss in our planning and our strategy is that there are cultures in every single room that we're in. So every meeting, every conversation, every plan that you create, people are bringing different cultural experiences into the room. If you take a moment to acknowledge them, you will find the richness that is there for you to create something that's going to be inclusive. If you don't have those conversations, you will miss it, and we will be on the back end trying to do what we're doing now in terms of disparities. So start first and foremost with that.
Thanks. And I know we're coming to the end of our time. I know the poll has launched. Before I go to the final question for all of our panelists, I want to thank you all for being here today and all of your presentations. I think they're so informative. I know from my own perspective, I learned so much both historically and what is happening. My ignorance on the topic, despite being in this field for 20 years, and really looking at, as you guys said, your own biases and your own experiences and how they have played a role, in this conversation and looking at this issue. So really appreciate you all being here. And Jason, I'm going to go to you first to just leave a comment. As you said, you're always the bearer of bad news. You were able to share some good news today. Any last point you want to leave with our attendees?
No, I just want to honestly recognize all our partners that you're going to give me this opportunity. There was a little bit of good news, but it's not lost on anyone. We have great partnerships in the state of New Jersey. And I can, from a national perspective, I can tell you a lot of states are envious of what we do here by working together with us, the Department of Health, the Department of Human Services, the Chief State Medical Examiner, the DEA, City of Angels, Prevention Links, and obviously the Partnership for Drug-Free New Jersey. We have so many great partnerships and people that are very committed and passionate about trying to help people. New Jersey Harm Reduction, there's just so many great organizations out there, and we're really working hard, and we still have a lot of work to do. But I just want to recognize that there's so many people out there working really hard at this problem, and we're just going to keep pushing.
No, thanks. Actually, to echo what you said and what the Attorney General said, absolutely together, collaborating, we definitely have a stronger impact. So thanks for that. And also, before we go to Dr. Johnson, thank you for, this is the last webinar learning series of 2021. And I know you participated in a few of them. So thank you for that. Dr. Johnson, any last comment for our attendees?
Well, I'm going to hit hard at the medical profession, and I have a habit of doing that. I'm concerned that there are still many prescribers who have prescribing practices that are a problem, that result in more opioids being prescribed than necessary, and that then contributes to this continuing problem. So we are hopefully working with the state to develop some approaches to that. But that's something that we have done. We, the medical profession, has to own. It's much easier to give someone a pain medication than not to do it. But we have to understand the consequences, and we have to make sure that we don't continue to contribute to the problem.
No, I think that's so important, and we'll definitely have to connect further, because looking at educating the prescribers in our state has been a main focus of the Partnership for Drug-Free New Jersey. We partnered with DEA New Jersey and HIDA, and under the leadership of Chris Yakum, to do a number of do no harm symposiums, talking about how to engage the medical community and just what you said on safer prescribing. And so looking forward to connecting with you further on this topic. And thank you so much for being with us today.
You're welcome.
And Jamie, I'll leave you to leave our last comment of the day.
Oh, thank you. I'm just going to ask a question. After hearing all of these presentations that were fantastic, and if you're a provider, community support, is there room for greater coalition in this fight against disparity? If you can answer that with a yes, then take advantage of the information. Make sure that you are approaching all of your moves in this space with cultural competence and with diversity and equity in mind. It will be the key to us winning.
Great, thank you so much. I hope that you will complete the evaluation for us. Again, I thank all of our panelists, all of our attendees. We have information on our upcoming webinar. It's going to be held on January 27th. We're going to be hosting Sam Quinones, the author of Dreamland, True Tale of Americans' Opiate Epidemic, which I know I'm sure many of us have read, and really provides that perspective on the historical roots of this crisis that we're in. Again, I want to thank all of our experts for joining us, all of our attendees. I know we're going over our time. If there's any questions that you were not able to get addressed, please feel free to email us, and we'll try to get those answers to you. But I wish you all a wonderful remainder of 2021, a healthy and happy holiday season, and be well, everyone. Have a great day.